The 20th century saw the development of a number of programs that provided a safety net for populations without health care. One of the first programs, Social Security, brought financial security to the elderly and disabled. Medicare brought insurance to the elderly and Medicaid insurance to children, the poor, and disabled. The Patient Protection and Affordable Care Act provides additional programs for those without access to health care, but still falls short of providing health care to all. The information in this chapter is designed to help you understand those in our society who are vulnerable to poor health and the factors that make them vulnerable. Our health system is continually challenged to address the social determinants of health that lead to poor health outcomes. The intersection of social factors, including where we live, our income, education, employment, and social networks, and health problems, predispose some and not others to be vulnerable. The factors in this chart characterize those individual factors that create vulnerability. For example, those who are very young or very old, those who belong to a minority race or ethnicity, those who have poor health, those that do not have health insurance, and those who have a lifestyle that does not include healthy foods and exercise. The environmental factors in this chart consider how where you live affects your health. Rural residents may not have access to healthy foods or health care. Neighborhoods with poor residents or neighborhoods with high employment and crime are generally not healthy neighborhoods. The text describes 3 different categories associated with risk for vulnerability: predisposing factors such as race and ethnicity, enabling factors such as lack of insurance or low socioeconomic status, and health need such as chronic conditions like high blood pressure or diabetes. Health needs can be physical conditions, mental conditions, or social conditions. There are a growing number of vulnerable populations due to an increase in chronic conditions such as diabetes and cardiovascular disease. The shifting demographics of the United States, with an increase in the elderly population and the inequality between the rich and the poor. And finally, there are not enough services available to support these vulnerable individuals in the communities where they live. The text describes the public hospital as the core provider of services to vulnerable population. This term may be a little outdated. Some states like Texas still do have public hospitals, but Oklahoma does not. It is true in Oklahoma we have hospitals like OU Hospital that serves a disproportionate number of uninsured patients. Federally qualified health centers like Variety Care in Oklahoma City provide services for the medically underserved with government support. There are many different types of FQHCs, such as community health centers, migrant health centers, healthcare for the homeless centers, and public housing primary care centers. Oklahoma has many tribal hospitals and health clinics, as well as Indian health services. Oklahoma also has rural health networks to support rural health providers. Oklahoma and most other states do not have enough mental health and chemical dependency services. Many of these services are private and not affordable to patients without insurance. Even if a patient can afford these services, there's frequently a waiting list. The Ryan White HIV/AIDS program provides medical, health, and support services to individuals with HIV/AIDS. Vulnerable populations have needs for social services, including food assistance, monetary assistance, and housing assistance. Without these basic necessities, it is clear this population cannot address their health needs. Who pays for vulnerable populations? The federal government is the primary payer. They pay not only for health insurance like Medicaid and Medicare, they also pay for programs that provide supplemental nutrition, housing subsidies, and financial support. States also share this burden with the administration of the Medicaid program and also frequently fund mental health and addiction programs. We sometimes forget the role employers play, as employers are the primary payer for health insurance. There's no doubt that the U.S. healthcare system is fragmented, with a huge variety of programs and payers that provide services for different groups of people. The system is reactive instead of preventive and values volume over value. We will discuss these issues in more depth later on in the semester. The Affordable Care Act, Medicaid, and Medicare have all financed initiatives to improve the health care delivery system. Some of the strategies are listed above. Care coordination is a mechanism to coordinate services to improve quality and reduce cost. Patients are becoming more engaged in their health care, demanding more price transparency and quality care. Multidisciplinary teams are an effort to break down the silos of specialty care and integrate care. The electronic medical record has created an opportunity for healthcare providers to use this data to improve population health. One example of this has been the use of emergency room data to determine what types of patients have excessive use of the emergency room, and the use of this data to develop community-based interventions to meet the needs of these patients. Provisions of the ACA included support for community health centers through increased Medicaid payments for primary care providers. The ACA also included payment methods to improve quality and contain costs, such as value-based purchasing, coordination of care, and integration of care. The ACA decreased the number of uninsured, but many still remain uninsured. There's still much debate about Medicaid expansion. Some states have expanded and others have requested waivers to provide more limited and less expensive coverage. The issue of undocumented immigrants is ongoing, with some states providing care and others not. Safety net hospitals lost some of their revenue from Medicaid disproportionate share hospital allotments and as a result of the Affordable Care Act, but they continue to provide uncompensated care. The ACA focused primarily on the healthcare system, which means it did not address social services needed by vulnerable populations to improve their health. Vulnerability is primarily a social issue created by social forces. To improve health, these upstream problems will need to be addressed.